Today's my talk is on something about radiology, as well as about the Diplipper chart, as well as, and of course, his chart. Radiology, if you see, most of the time we talk about CT scan, MRI recently. But for exam purpose, you must always should know something about the X-rays, different views, different questions can be asked in the examinations. So most important, you are supposed to know a few things about X-rays also. That is my advice. Learn something about X-rays. I'll tell you here few points of importance. When I asked the X-ray orbit, for example, X-ray orbit, never forget, almost all X-ray views are PA, posterior and posterior anterior. Almost all the X-ray views of the orbits are PA, except we have got one view called Townes view. Townes view is one AP view. One more AP view is there, that is called orbital venogram, which we are not doing nowadays. Previously, they were doing or identifying what are lesions in the superior ophthalmic vein. They were demonstrating superior ophthalmic vein in different positions, and they were able to identify a few problems. Of course, now we are not doing that. So naturally, there are only two AP views. One is Townes view, another is orbital venogram. Again, I'm stressing now, when you're asked an examination orbit X-ray, you tell PA, PA, PA. Nothing, that's all. You tell PA. Now, of course, these X-ray films, even though they are not commonly used, they can demonstrate the bony detail of the orbit as well as the face. They can show some soft tissue changes also. That is what I'm telling in one case. You take X-ray lateral view skull. This is a question common in examinations. When you see lateral view skull, you are supposed to see the sella area, that sella turcica. Now they will ask you, not only sella turcica, from the neck you can see a soft tissue going upwards. That means what? It can give us a clue regarding the nasopharyngeal tumors also. That's the importance of this lateral view of skulls. Lateral view of skull, the soft tissue changes can give us a clue regarding the nasopharyngeal tumors. Now, of course, these are all some of the facts. Orbital disease, the incidence of positive findings only 10 to 40%. That's all. Why this CT scan, MRI, and all score over this? The improved resolution of bones and the soft tissue with a CT and MRI. That's why they have decreased the use of plain X-ray studies. Of course, we are not using clinically. For exam purpose, yes, you are supposed to know everything about X-rays also. The different views, names, how they are taking, what are the various things. You are supposed to know everything. This is what the classical thing are supposed here. But plain X-ray, even though not properly commonly used, can give us something about useful informations when you are using it as a screening tool. For example, I tell you, I take X-ray orbit. I see the enlargement of orbit. I know some of the problems are there in enlargement of orbit. Suppose I see some enlargement of optic foramen. I know the causes may be the reasons for enlargement. Suppose I see calcifications. I know the common causes maybe of calcifications, maybe in the eye, maybe in the orbit, or maybe in the skull, the stellar region also. These are all the uses of, some of the uses of these X-rays when you use properly. Why we are not using anterior-posterior orbit and all? Because they are having a decreased clarity. We don't see the anterior structures properly. Because you know what is the AP view? The X-ray beam going from anterior to posterior, that's all. That means what the X-ray plate has been kept backwards. The X-ray plate has to be kept backward. That's called AP view. That's why you are not able to see any structures properly in the AP view. Posterior anterior view, yes, showing the improved clarity of the anterior structures. What you can see now here, you see the orbit. You can see the orbit and all, see the orbital rim and all. It's all very clearly seen. Whereas in this case, you are not able to see. It's an AP view. AP view, you are not able to see anything. Whereas in PA view, you can see all the structures classically. That is the advantage of doing a PA view of orbit, skull, anything. I already told you, X-ray orbit, almost all are PA, except Townes and venogram. Just know that they may ask in one examinations questions, what is the role of this Townes view? Never forget that Townes view is used to visualize the inferior orbital fissure. That can be seen in Townes view clearly. That means the problem is there, you can identify, that's all. That's the most important thing. Inferior orbital fissure, which is present between, another exam question, that is present between the maxilla and the greater wing of sphenoid. This is an exam question for you. The inferior orbital fissure is present where? Your answer is, sir, between the greater wing of sphenoid and maxilla. Don't get confused here. Don't tell lesser wing and all, don't tell. Your answer is greater wing and maxilla. There's a lesser wing of sphenoid, sorry, there's greater inferior orbital fissure is there. Other views are what now? As far as the orbit is concerned, we have got what is projections, what is view, Caldwell view. Other things, of course, lateral projections and basal projections and all. Basically, what we are talking about is Waters and Caldwell. What for these are used? I'll tell you here. Other view for, we got oblique apical projections of optic canals. You see the optic canal here, here's the optic canal here. This optic canal view is called as Rees view or Pfeiffer's view. Just know this, foramen, optic canal can be visualized in what view? Which view they will ask in exams? Your answer is Rees or Pfeiffer's. Then other views I told you regarding Stenberg. Stenberg, they may not ask you. By chance you are asked. The role of Stenberg view is what for? Your answer is to visualize the internal acoustic meatus. Where you can have what? As to, we got so many tumors, acoustic neuromas, so many things are there. We got problems of acoustic neuromas and all. That is called cerebellopondylitic tumors. They can have a problem in the internal acoustic meatus area, which can be visualized. To see that internal acoustic meatus, we have got one view called, the name called Stenberg. Just know the names. Rees view for optic foramen, never forget. Stenberg for internal acoustic meatus. Caldwell view. Caldwell view, what for? Your answer is superior orbital fissure. To see with superior orbital fissure, we need a Caldwell view. Waters view, what for? Your answer is Water view is for maxillary sinus, orbital floor and roof. So Waters view means orbital floor, roof, and I told you. Understand now? These are all the classical things, orbital floor, roof and all, and as well as maxillary sinus. These are all the classical things of the structures that can be visualized with these X-ray views. This is what a clue I used to give it. I used to give the clue. One more, I already told you now, all views are PA, except Townes and venogram. It's a classical question again. I told you superior orbital fissure, Caldwell. Inferior orbital fissure, Townes. Maxillary sinus, orbital floor, roof. Maxillary sinus, orbital floor and roof, Waters. Optic foramen, Rees or Pfeiffer. How to remember now? Just remember these words. Yes, C. Superior orbital fissure, Caldwell. IT. Inferior orbital Townes. Inferior orbital fissure, Townes. MOW, Mo. Maxillary sinus, orbital floor, roof, Waters. Just know this. One more important point, when you take X-ray, these are all PA views. That means what? The X-ray is coming from posterior to anterior. The X-ray plate has to be placed anteriorly, it has to be kept. When you keep the X-ray plate anteriorly, I will tell you, water's view, as if, you drink water. That means what? The X-ray plate can touch the skin. Maybe slightly away from nose, or may touch the nose also, doesn't matter. The X-ray, waters mean, just imagine water. Drinking water. What can happen now when you drink water? Maximum can touch the chin only. So the X-ray plate will touch the chin. What about Caldwell? Here, the X-ray plate will touch the nose and the forehead. Nose and the forehead. That's the Caldwell view. X-ray plate has to touch there. Whereas Rees view is a lateral. The X-ray plate is slightly kept laterally. That's enough if you know this. No need to bother about all the sorts of degrees and all. Just know this. In water view, the X-ray plate will touch the chin and maybe slightly away from nose, or even touch the nose. Doesn't matter. Caldwell view will touch the nose and the forehead. Rees view is a laterally placed view. That means the X-ray plate is slightly laterally placed. These are all the common things. The question can be asked in X-rays. And few more things I'll tell you. You can say now, I already told you, in water view is what? The chin up to sip the water, that's all. Chin. The chin is touching the X-ray plate. Can you see this X-ray plate? Here you see now the X-ray plate touching this thing. The chin. This is what the X-ray plate touching the skin means what? As if you're drinking water, man. That's all. Just remember this. It's not because of water is a person's name. That's different. Just remember things for exam purpose. You should know this. Other findings in X-rays. See, they will ask you one question. They can project this slide and ask you, what is this, doctor? You will tell now, sir, X-ray, sir, PA, sir, orbit. You will tell now. By seeing this, you can tell, sir, one side orbit is okay. You don't find. Other orbit, something hazy. Some radio opaque area is there. At the same time, you see the extent of the orbit is enlarged. The extent of the orbit, that means the orbital opening is enlarged compared to the other eye. Other side. That means what? You tell now, your answer is, sir, orbit is enlarged, sir. Orbit is enlarged, sir. How do you classify the enlargement? There are two ways, sir. Two ways. One is what? Generalized enlargement or a localized enlargement. Let that be tell in the exams. When you're asked about orbital enlargement, is there in X-rays? The same thing can see in CT scan also, doesn't matter. But we are talking about X-ray only. Sir, orbit is enlarged. Say generalized enlargement, sir. That means what? It has to be something in the orbital, the apex cone area. It's a long-standing, prolonged lobe, compressed. Something pressure is coming from inside. Hemangioma. Classical example is hemangioma. Hemangioma will produce a generalized enlargement of the orbit. Exam question over. Next is what? A localized enlargement. That means what? You can have a lacrimal gland problems, tumors. We can have lacrimal gland, suppose a benign tumor. I can have a molding. The bone molds to hold the tumor. Molding take place. Whereas in a malignant tumor, there will be destruction of the bones. Just know this, it's a localized enlargement can occur in classical, for exam purposes, lacrimal gland tumors, molding like benign tumors, destruction of the bones in a case of malignant tumors. This is the way you tell now orbit is enlarged, a common question in examination. Another thing I'll tell you, sometimes they can ask you, doctor, you see now optic foramen is here? You see the optic foramen here? Optic foramen is here. Now we see here also optic foramen, they've shown some here. They will ask you, optic foramen is situated which bone? Of course, the X-ray is there. Examination, we can ask you some anatomy also. Optic foramen is situated in which bone? Don't forget, it is in the lesser wing. Your answer, the exam answer should be between the two roots of lesser wing of sphenoid. Between the two roots of lesser wing of sphenoid is your optic foramen. Don't tell body and all these things, don't tell in the exams. Optic foramen is this. Now, what's the normal size for optic foramen in X-ray? They will ask you, what is a normal size of optic foramen in X-ray? Exam question again. Your answer, sir, approximately 4 to 6 millimeters, sir, average. Your answer should be 4 to 6 millimeter optic foramen enlargement. Sorry, size. Then they will ask you, when do you call it as enlarged? Suppose only one side optic foramen is shown, other side not shown. You measure it. If it is 7 millimeter, tell it is enlarged. That means what? If the optic foramen measures 7 millimeter, that enlargement is there. If one side is only shown. By chance, I have shown both sides optic foramen in the same picture. Right optic foramen, left optic foramen. I measured now. See now I measured. Suppose right is 4 millimeter, left is 5 millimeter. See now, I told you 7 is enlarged, agreed. Only one side is shown. Now I am having 4 and 5. A difference of 1 millimeter is sufficient to call it as enlarged. A difference of 1 millimeter between right and left optic foramen is considered to be enlarged optic foramen. Suppose one side only shown, you take as 7 as okay, enlarged. Next question. Okay, doctor. Now we have got enlarged optic foramen is there. It's a smooth enlargement or irregular enlargement. What are the causes? Exam question again. What are the causes for your smooth enlargement? Never forget, never forget. A smooth enlargement can occur in one, glioma going backwards. Glioma, optic nerve going backwards can enlarge the optic foramen smooth. That means there is no distraction, man. That's all. Another thing is, you got one more point you are supposed to know is retinoblastoma. Tumor going backwards, spreading towards the chiasma area can have a smooth enlargement. Don't get confused. Retinoblastoma also can have. Then what about the irregular enlargement? Classical meningiomas, optic nerve sheath meningiomas. When they go backwards, they can produce hyperostosis, which can result in irregular enlargement. Never forget these are some of the points. Exam questions again. Don't bother about. One more thing is here, they can ask you, sometimes I can have irregular enlargement, doctor, but there's no tumor here in the orbit. Your answer, sir, sometimes they can have a raised intracranial pressure, which can give a pressure over the inferior orbital rim, which can destroy. That means what? I can have an irregular enlargement even in a case of raised intracranial pressure. These are all the classical questions again. Can you see now? One more thing. In X-ray itself, we'll ask you, doctor, you know, sella turcica, the pituitary is there. These are some of the common questions. Now, sella, you know, it's called a Turkish saddle. No, that doesn't matter. It's a name. See now, we have got anteriorly, we have got this is sphenoid sinus. This is sphenoid sinus here. See the sella turcica here. The anterior clinoid process, posterior clinoid process. This is called tuberculum sellae. This is called dorsum sellae. You know the beauty here. You know, between the anterior clinoid process and the posterior clinoid process, we have got a sheath there, dura mater. That is called the dorsum sellae. Sorry, that's called diaphragma sellae. Diaphragma sellae. Never forget the classical question again. We have got a diaphragma sellae extending from anterior to posterior in the sella turcica. You know the exam question again. You see that they said the diaphragma sellae. Imagine a diaphragma sellae is there. Now somehow imagine a pituitary is here. Pituitary is here. Now exam question again. What? The gap between the sella, the diaphragma sellae and the pituitary is about 10 millimeter. 10 millimeter gap. This is what classical question. I tell you, they will ask you, doctor, pituitary has to enlarge how many millimeter to produce compression over the chiasma? What is chiasma now? Chiasma is lying over your diaphragma sellae. So naturally, it has to enlarge minimum 10 millimeters. Then only can compress, touch the diaphragma sellae and compress your chiasma. Understand now? Exam question is what? There are two things. Anterior clinoid process, posterior clinoid process, then you got diaphragma sellae and the pituitary, the gap is 10 millimeter. The pituitary is to enlarge at least 10 millimeter to produce a compression. These are all the common questions we expect in exams. Again, don't bother about basics, only you are supposed to know. Next is what? Other question they will ask you in examination. I'll tell you how we are going to ask you. See now here, this is what the depth of sella. This is what the length of sella. Just those 2 points. Depth of sella and length of sella. You should know the normal values. The length of sella, length is about 10 to 15 millimeters. The length. The depth of sella is about 8 to 10 millimeters. These are the points you are supposed to know when you are given X-ray of X-ray skull, lateral view and all. The chances are there they can ask you about sella because you can't escape. The reason what? Why I'm telling them this 10 to 15 millimeters the length I told you, anterior posterior length, they will ask you, when do you call sella is enlarged? When do you call the sella is enlarged? Your answer, sir, if it is 17 millimeter I measured, definitely enlarged. If it is 17 millimeter, the sella is definitely enlarged. This is a common question. Again, I'm repeating now. Few points. The pituitary has to enlarge minimum 10 millimeters. Exam over. The length of sella, anterior posterior length of sella should be 17 millimeter to call it as enlarged. There are so many points regarding sella. These are the basic points. Next is what now? Can you see? I told you. Epiphanical, posterior, I told you that depth of sella, everything I told you. Same thing only. Normal dimension, I told you. He has given now 4, of course, maximum 12. I told you 8 to 10 is enough. Now length, I told you 10 to 15. That means what? He has given 16. This range. At least know that sella is enlarged. Anterior posterior length should be 17 millimeter or more. You call it as enlarged sella. Finished. Can you see now here sella? These are all the sella area. See now, can you see the enlargement here? Can you see the enlargement here? See the sella here. Compare this. The sella enlarged. Now they can ask you a few questions here. Doctor, there are sella itself, you know, you got dorsum cellate, you got tuberculum cellate and all. Sella, I think a saddle. Now sometimes, see now, the variant morphology, that tuberculum cellate, that means for the anterior part, not the dorsum cellate. The anterior part of the sella may get flattened. That means what is like this, man. It gets flattened. It becomes like this. That means what? A J-shaped sella. J-shaped sella can occur. That's one of the problems you can see. Sometimes you can see. Dorsum cellate remains rounded and forms the loop of the J. J-shaped sella is a variant. Suppose I get J-shaped sella, what are the various DDs? What are the various DDs for J-shaped sella? Exam question. Just remember con man. Just remember con man. Con man. Just remember con man. What is C? Con man word. Chronic hydrocephalus. O for optic chiasma glioma. Just do one point. Con man C. Hydrocephalus chronic. Optic chiasma glioma. N for neurofibromatosis. M for mucopolysaccharidosis. A for achondroplasia. N for normal variant. J-shaped sella can also be seen as a normal variant. Again, I'm telling you now, J-shaped sella. Remember the clue, con man. If you're not able to remember, at least few points, try to remember now. Glioma, you can tell easily. Even normal variant, you can tell easily. Mucopolysaccharidosis, you can tell at least. Other things you are not able to remember, doesn't matter. Doesn't matter if you're not able to remember anything. At least few points, sir, it can be normal variant, sir. Sir, mucopolysaccharidosis, sir, it can occur. Sir, glioma, sir, optic chiasma glioma can occur. These are all some of the points you are supposed to remember for exam purpose. There's a J-shaped sella. One more thing is there, we can have a double floor sella is there, double contour. It's called double floor sella. Of course, the reasons are not given. Just know this for our purpose. There are something condition called double floor. One more important exam question you cannot escape as far as sella is concerned. Nobody can escape. What is that? What is empty sella syndrome? What is empty sella syndrome? Your answer is, sir, sella is there, agreed. The pituitary has to be there. I find pituitary, something is appears to be not or is something not there. Like this. That's a clue. Something we cannot tell definitions. See, now we got now empty cella syndrome is a rare disorder. Malformation or absence of pituitary gland in the cella. This is called empty, as if the cella is empty. Then next question. Oh, very good. Now tell me the cause. Tell me the cause for the empty cella. How will you classify empty cella? It may not be asked in examinations, in clinicals and all. It may be asked in your theory purpose, theory examinations. Your answer is what now? Empty cella can be, there are two types, sir. Primary empty cella, secondary empty cella. Let me tell. Primary empty cella and secondary empty cella. What is primary empty cella? What is primary? I'll tell you. What is primary? Okay, I'll tell you. What's happening here now? Primary empty cella. There is a gap somewhere in the diaphragm cella. The primary itself. We don't know the reason why the diaphragm cella has a gap. That means what do you mean by that? We have got the CSF pressure is directly being transmitted into the cella area and compressing the pituitary completely. That is called primary empty cella. That means what? Cella either partially filled with cerebral spinal fluid or the cella completely filled with fluid also. That's all empty cella syndromes. The pituitary may or may not be something completely compressed. This empty cella means your God CSF is there. What is primary empty cella? I will tell you. Primary empty cella, can you see this? Normal cella is like this. Can you see the normal cella? See the partially empty cella. See now CSF is here. And it's, of course, now we see the complete CSF here, the completely empty cella. This is the way they got descriptions. Is a complete empty cella or a partially empty cella. Now I will tell what is the same thing only. CSF is complete here and CSF is, can you see this? CSF, normal CSF. This what is sphenoid bone. Never forget the sphenoid bone, we got cella. What is primary empty cella, secondary empty cella? Again, I repeat. Can you see here this picture? This is called diaphragm cella. Can you see this? This is called diaphragm cella end. And this is a central opening of the diaphragm cella. Inside, you got a pituitary fossa here. These are the various things. Just know this. Now, what's happening now? There's a gap, a gap is there in the diaphragm cella. Suppose the pituitary is there. Normally, the gap should not be there. Actually, the gap is there. Now, primary empty cella, what happens now? We have a weakness in the membrane. The diaphragm cella that normally covers the pituitary gland, the weakness is there. What happens now? The CSF fluid can leak to the cella turcica and apply pressure on the gland. What will happen now? This can lead to either a flattening of the pituitary gland or expansion of cella turcica, giving the pressure empty cella. It should expand the cella, man, or it can compress the pituitary, that's all. Primary empty cella, what do you mean by that? The diaphragm cella, the dura mater above the cella has got some defect which can allow the CSF to pass into that, compressing pituitary or enlarging the cella. This is called primary empty cella. How to follow? Now, secondary empty cella is what? Now becomes because the pituitary gland might have been removed surgically or maybe radiation therapy. It's a classical question. They would have given radiation for tumors around the chiasma, which can give rise to a problem with the pituitary, compressed, damaged. That is called secondary empty cella, means because of surgical removal of pituitary or because of radiation therapy around that, or maybe sometimes a pituitary tumor is there, a sudden hemorrhage into the tumor called apoplexy. Pituitary tumor, we can have a hemorrhage which can produce a apoplexy. This is what is called secondary empty cella. These are all the common questions. I described about what is primary empty cella, what is secondary empty cella. I told you what the gap between this pituitary and the cella, diaphragm cella, 10 millimeters. These are all the common questions. You know why I'm telling you now? They will ask you, doctor, the patient has got an acidophilic tumor. Acidophilic means a microadenomas. Basophilic tumor of pituitary is a microadenomas. Chromophobes is a macro. That means what? The chiasma compression because of pituitary is more common in chromophobes. Macroadenomers, micro can produce, doesn't matter. But macroadenomers are notorious to produce chiasma compression going for field defects and all. That is the important question for your exams. Understand now? Now, question now. Okay, doctor, I'm having empty sella. Is there? Pituitary is compressed or pituitary something is there. What will be the symptom for the patient? Exam question again. What will be the signs and symptoms of the patient? Your answer, sir, usually no, sir. Most people with empty sella do not have symptoms. Okay, only often detected because of you take brain scans and find it out. Very rarely they can have what? Maybe headache, whatever thing is there. Vision problems. Because the chiasma compression, they can have vision problem. That's all. Okay, that means usually no symptom. Suppose you're asked exams, the signs and symptoms of empty sella. You tell now, sir, usually nothing, sir. Very rarely they can have headache, sir, and some disturbed vision, sir. Finished. Okay. Primary empty sella is common in whom? In normal population. Normal population is very common. Of course, frequent in women. Frequently seen in women than men. Whereas secondary empty sella, no need. Both genders can be affected. Anybody can have tumor, man. Anybody can have a glioma. That's why secondary empty sella the gender may be equal. Whereas primary empty sella is supposed to be more common in females. Is it empty sella is inherited? Exam question again. We'll ask you purposely in the exams. Your answer is not. No inheritance pattern. No inheritance pattern of empty sella. Finished. Don't bother about that. Next. See now here is also common exam questions. Few more exam questions I'll tell you. Here. Doctor, you are having some calcifications. Calcifications in the sella region. Can you tell me possibilities? One question, exam question. Your answer is yes, sir. Calcification can occur. Physiological calcification. Classify like this. Physiological calcification. One point is enough. Pathological classification. Divide like this. Pathological classifications. Physiological normally can occur where? Your answer is, sir, above sella and all, you got pineal body, sir. This pineal body can have calcified, sir, in the old persons. It can be a physiological calcification, sir. Enough. What is pathological calcification? Sir, can be toxoplasmosis, sir. Toxoplasma can produce calcifications in and around the sella. Or even you can have internal carotid arteries there, internal carotid arteries there. I can have a curvilinear calcifications because you got atherosclerosis. So many things happen. So naturally, we can have what? Curvilinear calcifications in the internal carotid artery can be seen. A calcified area around the sella. Now with this exam question is what? You know what is called Albal sign? ALBL. Albal sign. Albal. What is Albal sign? Albal sign is what? The curvilinear calcification of internal carotid artery around the sella area. That is called Albal sign. Albal. ALBL sign. This is what I want to stress. Classical, I told you about something into orbital views. I told you about the Caldwell, all these views I told you, reason all I told you. Then I told you what the structures can be visualized with these views. Then I told you about the skull lateral view, skull, sella. I told you about dimensions of sella. I told you. Then I told you something about the primary empty sella, primary empty secondary empty sella. These are some of the points. Now I told you something about the calcifications in and around the sella. Common question examinations. Never forget. Now here's another point of exam questions here. They will project this slide. They will project this slide, X-ray slide. See, I'm giving importance first X-rays because X-rays normally we don't do now. So, but exam purpose they will show you. In examination they will show definitely. Okay, that's why I'm stressing importance for X-ray here. Of course, other things, CT scan, MRI and all, okay. But X-rays normally we don't do. For exam purpose, you are supposed to know few things. That is why I am stressing important X-ray now. Here is what now. Can you see X-ray now? So now this is what? X-ray PA view. X-ray PO view is here. It's a lateral view is here. Orbit. And you see now up, down positions and up positions. Can you see this? That means what? If you see here, this one X-ray to localize the intraocular foreign bodies. Localization of intraocular foreign bodies. Olden days, they were doing only X-rays. Of course, now you have got what? Ultrasonogram. You have got what? CT scan. Here also one important, of course, everyone knows that. When you have a metallic foreign body, magnetizable, MRI is contraindicated. That everyone knows. MRI, magnetic resonance, is contraindicated when you suspect a foreign body of magnetizable foreign body, like ions. So if at all I want to know foreign bodies nowadays, we do ultrasonogram or a CT, that's all. If I suspect a wooden foreign body, yes, I can go in for MRI. That's different. Now, for exam purpose, this X-ray plate used to detect or used to find out the location of foreign body with X-ray. You see here, can you see now here? This is a round picture. It's a round thing, ring-like thing. This is called a limbal ring. Limbal ring. It's called limbal. You know, we have got cornea, limbus. You have to suture this ring around the limb. Suture. One or two sutures. The limb, that ring will be kept in place. This limbal ring is made up of silver. Exam question. They will ask you, this limbal ring, if at all is made up of, you have seen, you will tell no. But if it is made of what material, doctor, don't tell steel at all. Your answer is silver. What the diameter of the ring? Your answer is 12 millimeters. Answer is 12 millimeters. You know, cornea diameter is 12. So natural 12 millimeters is the diameter of the this limbal ring. What you are going to do this? I suture the limbal ring around the cornea, around the limbal area, sir. And you take a PA view, sir. You tell now, sir, I will take a PA view. Once I take a PA view, sir, I can see a radio opaque material, sir. Because it's a radio opaque material, so foreign body going to localize. Foreign body only going to localize. See now, 12 o'clock. Now in PA view, what are you going to achieve? Your answer, sir, in PA view, I can see that a radio opaque material is there, and that also it is present in this case around 12 o'clock area, sir. That's all you can tell. It's around 12 o'clock area. You can tell now in PA view, limbal ring, I can see a radio opaque material at 12 o'clock. If you tell this, next question, oh, very good, doctor. Very good, very good. Now I'll tell you. Say, what is the name of the ring, doctor? Don't tell limbal ring. It's a limbal ring, agreed. What's the name? What's the name of the ring? They will ask you in exams if I come. If I come as a referent, I will ask you. Your answer is Spath. S-P-A-T-H ring. Spath ring. Spath ring. The limbal ring name is Spath. Never forget this Spath ring. There are so many names given that just know Spath. Some examiner think it's called a stellar. Doesn't matter. They will tell stellar. You tell at least Spath. The name you pronounce as Spath ring. 12 millimeter diameter. Made up of silver. You keep it over limbus and suture and take a PA view. You see what now? You see now the radio opaque material at 12 what clock position is present, the foreign body, if at all. Then the problem is what? I do not know whether it is inside the eyeball in the orbit. How do you know? Now I want to do some more X-rays. You tell this in the exam. Sir, when I see this, I know it's 12 o'clock, sir. But I do not know, sir, whether it's inside the eyeball or outside, sir. I can't tell. Then what to do? Sir, I will take a lateral view, you tell. Lateral view. See the lateral view here. The lateral view is taken. That means what the limbal thing is like this. Now you see a light line, like something like that line. What I will do now? In the X-ray plate itself, you have to do. In the X-ray plate itself, you have to draw. How to draw? From here, the lower margin, the lower limb. You know, you got a caster with a caliper. You know, caliper is there. Measuring and all, calipers. When you do cataracts and all, you are using, you know, calipers. That caliper you take, you keep it 12 millimeter. You keep it at 12 millimeter and keep the caliper one end and the 12 millimeter here, you make an arc. Same way, you keep the caliper in the upper end and make an arc. Now you can see the central here. See, keep the caliper one end here and draw a circle draw a circle. That means what? I have drawn a circle having a radius of 12 millimeter. From top, 12 millimeter, one arc. From bottom, 12 millimeter, one arc. Intersection is there. From intersection, you keep one limb and draw the circle. That means what? This circle will have a diameter of 24 millimeters. 24 millimeter is there for the circle. You know the meaning here? That means I have constructed an artificial eyeball of 12. We know you average diameter of the eyeball is 24 millimeter. That means I have constructed an artificial eyeball here. In the lateral view, on the X-ray itself, I can construct. That means what? I can see the foreign body here. The line, the circle is here. See the foreign body is outside. That means what? I know, sir, this foreign body is outside. Foreign body is present outside. This is what the exam question again. Now the next question will start. Okay, doctor, you have constructed an eyeball for 24 millimeter. Agreed. But this 24 millimeter is not for everyone. How do you know? Each eyeball is different. Somebody can have 26. Somebody can have 20 millimeter, or you will follow. Some hypermetropia, some myopia, so many fellows are there. So naturally need not be 24 for all. This what exam question again. Your answer is what? Sir, 24 millimeter constructed, sir. In this case, I am finding it outside, sir. But still I am having doubts, sir. Maybe intraocular or outside the extraocular. Then how to confirm, doctor? How to confirm whether it is, that is called the fallacy. This is called the drawback of this procedure. The drawback of this or fallacy of this procedure is what? When you constructed a lateral view, artificial eyeball, you are constructed for 24 millimeter, need not be always for all. Somebody can have 20, somebody can have 26. So that what I have found out is maybe wrong. To overcome that, what I will do? I will take X-ray again, the lateral view, looking down, and up again. You ask the patient to look down and take X-ray. You ask the patient to look up and take X-rays. Now we see the foreign body inside the eyeball will move along with the movement of the eyeball. Whereas the foreign body outside the eyeball will not move. This way you can tell in exams. Sir, I will take lateral view, find out the problems, and I will ask him to look up and down. I take two views now, and I see the movement of the foreign body is in with the movement or outside. You can know that eyeball moving up, the foreign body also can move up. Eyeball moving down, the foreign body also can moving down. Sometimes what happens? Contrarily, what now? We can have eyeball moving up, the foreign body can come down. Eyeball coming down, the foreign body can go up. That means what? Some movement is there. Movement of the foreign body is there inside the eyeball. That means it's inside the eyeball. If it is not moving, it's outside. Like that you can tell. Okay, I will follow. Now the question is what? Okay, doctor, I'm having this is images of eyeball, and this is a center of rotation, 12 millimeter area. Okay, this anterior, the posterior. Imagine now my foreign body is inside, in front of the center of rotation. In front, not the point, in front of center of rotation. That 12 millimeter. If I move up, this will also move up. If we move down, this will also come down. If we imagine now, if it is behind the center of rotation here, when I move up, it come down. When I move down, it goes up. That means opposite movement is there. So always remember now, if the eyeball moves up, the foreign body also moves up. It is in front of center of rotation. If the foreign body moves against, if the eyeball moves up, the foreign body appears to move down. That is opposite direction. The foreign body is behind the center of rotation. This is the way you have to tell in the exams. One more drawback here also. We'll ask you, what's the drawback here, doctor? You're told, okay, agreed. What's the drawback here? Your answer, sir. Sometimes the foreign body in the center itself, the center of rotation itself, when I move up, down, no movement, but intraocular. Or to follow up, that means a foreign body on the center of rotation itself will not appear to move in during movements of the eyeball. That's a drawback here. One more drawback, examiner may or may not agree, I'll tell you. One more drawback here. See, sometimes foreign body is outside the orbit, you see now. Okay, outside a bit. But what happens sometimes, what happens? So outside means what? When I move the eyeball, the foreign body will not move. You know that. When I move the eyeball, the foreign body will not move. Very rarely what happens, the foreign body traverses during the traversing that area. No, that means what? The pathway, some fibrous tissue can grow and get attached to the foreign body. In its pathway, fibrous tissue can proliferate and get attached to the foreign body. That means when I move, because of fibrous tissue contraction, the foreign body also appears to move. But many examiners may not agree. Just tell the chance is there. If at all, if I ask you, tell this point. But so far, what now? Sir, in PA view, I know what position. Sir, 12 o'clock, 3 o'clock, like that we can tell. Sir, I want to know, I want to construct artificial eyeballs on the X-ray plate. You take an X-ray lateral view. Sir, you take a caster with a caliper. Sir, you keep 12 millimeter radius, something length. You keep from top, one arc, from bottom one arc. Keep it a center and draw a circle. That is called 24 millimeter diameter. That is supposed to be the axial length of the eyeball. That means what? I have constructed an artificial eyeball here. Now the foreign body is outside. I know foreign body is outside, but some drawback is there. Because of what? The difference in length of the eyeballs in different persons, patients. Now I'll ask him to look down and look up. Sir, if I see the movement is there of the foreign body, it is inside the eyeball. If it is not, it is outside. Inside itself what? If it is in front of center of rotation, it moves with the eyeball movement. If it is behind the center of rotation, it's moving behind the center of eyeball. Understand? If it is behind the center of rotation, it moves against. I told you drawback what? The foreign body in the center of rotation itself will not move. Now foreign body outside the eyeball still can show some movement when a fiber is proliferating. That if you're asked to tell, don't tell otherwise, because they may not agree sometimes. This is what a classical picture of localization of foreign body with X-rays. Nobody can escape this exam questions. Of course, we are not doing, agreed, we are not doing this, but for exam purpose, for historical purpose, you know the history. How they were doing, struggling to look at the foreign body those days. Of course, you got a lot of this thing, we got CT scan, everything is available. But those days, when I was a student, we used to do this. We used to stitch the limbal thing and all. That's why I'm telling you now, be careful. Sometimes some examiner centers are very notorious for asking this type of questions. Never forget this. Name of the limbal thing I told you what? Spathe. Diameter what? 12 millimeter I told you. Material is what? Silver. These are all the common questions you can expect.